All right, very good. Hello, everyone. We've made it to the middle of March. I haven't seen all of you since November. November was our last training, unfortunately, for the year with everything that was going on. And I was actually on lockdown because there was so much COVID around. And I'm one of those people who COVID would probably finish off. And so I have not been doing any trainings since that time. The training staff here is going to educate me at some point about how to do my own version of training, and we're going to put it on YouTube. So just so everybody knows, we're not going to miss a month again. And moving back towards in-person training as soon as we can, as it is safe to do. November was a bad month for me as well. Much of my family got sick with COVID. My son's father-in-law, who is a fire lieutenant paramedic in the Dayton, Ohio area, contracted COVID and died. A healthy 52-year-old. His daughter married my son. They have two kids. And then Jeff himself had two teenage boys. He contracted the illness and went down for no reason, and that's the way COVID has been. And so it takes out a healthy 52-year-old paramedic lieutenant, career firefighter, and what a loss. A number of other people got sick kind of with the same strain, and my son was one of them, and he was very ill. My daughter was ill with the disease when she was at 37 weeks of pregnancy. Fortunately, she did well, and our grandson was born and has done well. A number of other departments have had significant stresses related to COVID, and so training's kind of been on the back burner for a while. We're in a new time, so March. We are at a period where nationwide the disease rate is falling. Some of that is probably common for viruses and is being reflected in the current COVID. You know, the scientists are worried about the variants, and that's an appropriate thing to do. But right now, it doesn't look like the variants are going to cause any more widespread outbreaks right now. We are well into the vaccination program, and thanks to all of you who took the vaccine, like I did. As soon as I could get in the chain, I got both of the vaccines. I happened to get the Moderna. We're at the point now where Johnson & Johnson will be coming available soon. It has been approved under emergency use authorization, but it has not been widely available because they haven't manufactured a lot of it yet. It's being manufactured in the U.S. Sometime within the next weeks to month. It should be available in larger quantities and be added to the stream of vaccines that are available. That is really good news for all of us. 3 vaccines. We will have the AstraZeneca added to the mix at some point, and another one called Novartis. Some of you have been asked to be part of the phase 3 trials for Novartis. One of the clinical sites is in Tampa, and it's another 2-shot vaccine. It is a different mechanism of working than the existing vaccines now. So it's likely we'll have 5 vaccines available at some point in the United States, and maybe more. Worldwide, we are a little behind some countries like Israel. We're way ahead of many other countries. It is likely international travel and events will be occurring anytime soon. But domestically, my opinion, and what I share with the IFC and IFF is that July the 4th will kind of be the reopening of the country to a new normal. I think by then, everyone who wants to get vaccine will be vaccinated. We will be at herd immunity status because so many people will be vaccinated. I ask all of you to get vaccinated. It is a good, safe vaccine. It is effective. It will help us return to normal in the stations, return to normal in our education, protect you and your family. We are still working on vaccines for people under the age of 16. I happen to be very well versed on what is going on with the vaccines in the next age group, which is the 12 to 18 age group. One of the vaccine test sites is in Cincinnati at Children's Hospital there, and they will continue to work on reducing the ages for vaccine testing, and eventually we'll get to the over 12-year-olds, and then over the 6-year-olds, and then over the 2-year-olds, et cetera, as we move through the entire population. All good news, but you can start at your age with yourself getting the vaccine, and then others who are eligible in your family, please encourage them to get vaccinated also. All right, what else is going on in the COVID world? We're learning more about the disease. We are learning how the immune system reacts to it and trying to figure out how to treat it once you've gotten it. Fortunately, again, many people who get it only get mild presentations. We have not been as successful in trying to find treatments for it once you have it. And those that head down a more difficult course, we have modified what we are doing, but not a whole lot has changed in the last year that we've had this disease. We make aggressive use of oxygen, try to keep people off ventilators. We try to prevent any other sources of infection, prevent clotting for those people who have the disease, because that's another addition to the life threat arena. And for those who need critical care, we're a little bit better in tuning up the program that is needed for critical care for COVID patients. The GI illnesses that go with it also are vexing, but we've figured out giving IV fluids and some nausea medicines is really good for the people who have GI symptoms with it. And then the kids who've had it, we're making use of steroids and other anti-inflammatory drugs to keep them from getting that multi-inflammatory syndrome that children get with viruses, including COVID. So that's on the treatment side. On the PPE side, many more good PPE elements available to us now. Supplies have come available. So please make use of your PPE. We are still in the universal precautions time of use of PPE in our work with patients. I think it will be within a month when we will be back to multi-company training and when we will be back to reduced use of masks in the station. So here I am with my mask. I wear it all the time, and when I'm out in public, I take it off when I'm at home. I've limited my contacts. I stay out of the 6 feet zone around other people. I stay away from people who are coughing and sneezing, which is becoming more common this time of the year. As we're heading now into yellow storm season and into respiratory season, we are back to using our full armamentarium of treatments for people who are wheezing, people who have allergies. Many of our patients need a nebulizer treatment, and the modification in your case is to take them outside and you stay upwind from them and let them use the nebulizer. If they're really sick, we start an IV and we give them Solumedrol for the advanced and the paramedics. And so we are into allergy season, and that as a cause of respiratory distress in people. And we talked about a year ago, those in real acute distress need 0.3 of epi in their muscle to assist them in being able to start opening up their airways. So we talked about epi as one of the important treatment modalities, along with a nebulizer for people with acute respiratory distress, acute wheezing, and those up in the tripod position. We also have Benadryl for acute allergic reactions, but a reminder, Benadryl is not a life-saving drug. Epinephrine is a life-saving drug. We have had, some people that have taken new medicines. I have been at the start of bee season already, and we've had a few anaphylactic reactions to bee stings. And a reminder again, the first treatment for bee sting anaphylaxis is IM epinephrine. It is not starting an IV. It is maintaining the person in the position that they're most comfortable and administering 0.3 for an adult and 0.01 milligrams per kilo for a child. Everything recently has been in adults. So really important that we focus on seasonal causes, and we're getting out of infectious season now that we're moving into late March and April. You guys probably heard flu is at an unprecedented historic low. Why is that? Well, people aren't traveling internationally to bring the flu from other countries. The whole globe is short on flu this year. People are wearing masks everywhere, and masks not only prevent COVID from spreading, but flu and strep and other respiratory viruses. So the use of your mask continues to be really important. And I think many of you come next fall are going to be comfortable again in public wearing masks still, not just because of COVID, but because it's really nice not having flu and colds and strep and other things. And so we're going to see a little change in behavior probably moving into the flu season later this year. Okay. All right, enough about COVID. And I have been keeping the chiefs advised of all changes in process and protocol, and I remain kind of the medical authority for the IFC in developing new practices and policies for the fire industry. Another really important element of what's going on locally here is Captain Gilliard has been working for a year to get us new drug boxes and to reset the drug boxes. There is an EMS consortium that Terrence Kearney is putting together, and we want to use that opportunity to build the drug box program that we need to make drugs available for the patient, make it easy for you to manage the program, whether you're an intermediate or advanced or paramedic. We need to be using our medicines to help our patients. And we still know that Grady, is having longer times to scene than we would like. So we sometimes end up on the scene longer than usual. So trying to get all those pieces in place and working with all of you who are very interested in improving that program, that's the next priority. And then to get the boxes out on the equipment and available for you to use in the form that you like them. For all of you interested, we're still having significant drug shortages. I looked at the report today. It's still 50 lines long, but it is much better than it's been for 4 years. Better than it has been in 4 years for our drug shortages for our medicines. So a more reliable supply of medicines going into our drug boxes so that then when you're reaching for the drugs that you need, we've got them available. We'll change how dextrose is provided. We still don't have some medicines available like dopamine and others that we'll have to find substitutes for. And then the other thing that is going on right now is Grady EMS is reviewing the protocols based on a little bit what we're going to talk about, which is the new forms of CPR and ACLS. And I want all of you to know, as best I can, I'm providing input to Grady, but for the most part, they're holding new policies and medical protocols close to them. They have not shared what they're going to do with me so that I can then begin to train you. As soon as they make new medical protocols available, and if we have input on them, we will do that and then fill our drug box appropriately and then do training on how to use any new versions of the protocol. So those are very important things going on to put the right tools in your hands and get medicines available and an updated protocol. Another piece of what's going on. We're gonna head into a time when everybody's going to be out and around and moving again. We will have new traffic problems, and coming in the interstate today and looking at the traffic on 285, man, people are anxious to get out and get traveling again. The airport is more full than it has been in a year that I have seen it. So people are going to be out moving. They're going to enjoy their time out. And so we should look at an increase in our runs and a change in the type of runs that we have. And I think we're going to be moving back towards more injuries, more motor vehicle crashes, et cetera. That's kind of the history of this department. But everybody's been sitting at home for a long time. We'll talk in the fall about what illnesses are likely to come back then. But for now, it's going to be about injuries and about people getting out of their houses. Okay, what I wanted to share with you today that's new and exciting is updates on BLS and ACLS from 2020. American Heart Association, as you know, every 5 years updates their medical protocols. The 2020 version was released in October. That 2020 version has the fewest changes of any 5-year change that I have ever seen. And so we can focus on just a couple of pieces that change, and then reinforce some of the things that over the last 10 years we have found work very, very well. Okay, so changes in the new AHA guidelines for doing CPR and providing advanced life support. Here's the following. Number one, if somebody's not breathing or has agonal breathing or looks like they're having a seizure without a seizure disorder and is not breathing, CPR is indicated. If you check for a pulse and can't find a pulse, it's time to get on the chest. And the chest rhythm continues to be between 100 and 120 beats a minute. There are a lot of songs that get you to 100 beats a minute. Keep singing them. Find the one that works for you. Walk Like an Egyptian, Dancing Queen, Sweet Home Alabama, Hips Don't Lie, Macarena, and Rock Your Body all are 100 to 120 beat a minute rhythm and provide you with what you need. Pulse checks stay very slow. If the patient is letting you press on their chest at 100 beats a minute and not responding, it's not time for you to come off the chest. AED goes on as soon as available, that you get them, you get the AED on the chest and let it go through its rhythm reading. It may ask you to quit compressions for a minute and then make a decision about applying a shock or not. And then you're right back on the chest again. They still have alternate placements for the chest leads, either across the front of the chest or front to back. Either one works well. And then get defibrillation done, because of course defibrillation is the ultimate treatment. For our paramedics, pacing, really nothing new. If the patient needs a pacemaker or if theirs has failed, and that's what happened this year. There are a lot of people who let their pacemaker batteries go unchanged. I had one of those in the emergency department who came in with a heart rate in the 30s, and he just said, you know, I have no energy, I can't do anything. And at the time, he was 2 months overdue for his pacemaker battery to be replaced. But because he was having trouble getting hold of his doctor in the middle of COVID, he didn't have it replaced, and his pacemaker failed, and he didn't feel well. Applying external pacemaker to his chest, and then giving him a little something to make him feel better. We made him feel better for a little bit and then turned it off as he went up to have his batteries changed in the cath lab upstairs. That's the kind of stuff that has been going on recently. And for all of you, need to get back into our sequence of regular checks with your doctors, getting the kids immunized with their regular scheduled immunizations, et cetera. And then moving forward in the healthcare system as we move into the fall. Okay, in our new world, doing our pit crew CPR, and I ask all of the crews, when you're doing some training, practice pit crew CPR, how to keep hands on the chest, applying compressions, 120 beats a minute, using the AED, and then letting the paramedics work around you. You do about 200 compressions, and then the next person immediately picks up with no pause for the patient who's still unresponsive. So those are really, really important elements, and pit crew is the way to do this effectively. It looks really good in front of the community. You feel good doing it that way. It is our professional method of delivering cardiac arrest treatment to patients in the most effective way until we can get them defibrillated or get a few medicines aboard that allow us to defibrillate them. So it's the basic CPR that keeps people alive. Ventilating people is still about giving 6 to 10 breaths a minute. asynchronous. It is not about inflating the abdomen, and ventilation should not interfere with compressions. In the drug world, epinephrine still the #1 drug, not replaced by vasopressin. For those of you who know about vasopressin, epinephrine is still our drug every 3 to 5 minutes. And then amiodarone or lidocaine for the paramedics for antiarrhythmics. We have moved forward with termination of resuscitation for patients who don't get any work done effectively with our CPR, and the medical control physicians are much more attuned to termination of resuscitation. That is typically after 15 to 20 minutes of care, and then we're applying the end-tidal CO2 to see if the cells are still working at all. So end-tidal CO2 is about exhaust gas put off by working cells. If no cells are working, there's zero carbon dioxide being produced. You could say the same about being in a home with potential fire. If there's no CO2, there's nothing on fire. If the human body is not producing CO2, it means the cells are all dead. And that's one of the confirmations that we have that people really are dead, is when their CO2 level is zero or in the very small single digits. We have had approval with the new ACLS about the compression devices. I'm still not a big fan of those, but they do save our people in terms of getting to the hospital safely, and evenly applying compressions across a period of time that it takes to get to the hospital. What we like to look for is post-arrest care. That means somebody has returned spontaneous circulation. And when they return spontaneous circulation, the AHA guide now calls for us to do some new interventions to keep them from going back into cardiac arrest. And then when they get to the hospital, cooling the brain so that we preserve brain function. For all of you, that really is the basic changes with 2020 ACLS that relate to field care. All of them important, all of them brought together when your crew on training time practices doing effective CPR according to the pit crew methodology, which is 3 people rotating around so that nobody gets too tired, 1 on the chest, 1 watching the airway, using an oropharyngeal airway or the eye gels as needed, bagging as needed, the 3rd person working the AED, and then rotating those positions just like a pit crew does. And then when our advanced life support provider gets there, IV, starting medications, using the manual defibrillator if it's indicated, and putting an endotracheal tube in place. So those are all parts of new ACLS for out-of-hospital cardiac arrest care. Let's go through a scenario. So we go out for a patient, and we have, let's just do a straightforward, I'm short of breath, and you find a 62-year-old man who says, I'm short of breath. You begin to interview him. What are you doing? What happened when this, what was going on when this started? How long has it been there? Do you have a medical history on medicines? Have you taken anything? He gives you a pretty basic history. It started an hour ago. I wasn't doing anything funny. I haven't had this before. I'm on no medicines and have taken no medicines. I'm not on aspirin. My wife is here. She thinks I need to go to the hospital, but I'm just short of breath. You ask him specifically about having any pain, and he says no. You put a finger on his pulse, and you feel a regular pulse, and let's say the rate is in the 60s. You get a blood pressure. It's 140 over 110. And you put him on our pulse oximeter. His pulse ox reading's 98%. That feels pretty good so far, doesn't it? You listen to his lungs, and he's not wheezing. And he's moving air well and is in no respiratory distress. So Grady's not there yet. You're thinking to yourself, what could be going on to this guy? Well, short of breath, 62-year-old man without a history. Let's get him some aspirin. We can do that at the basic level. We administer 324 milligrams of aspirin. He says, I'm feeling short of breath again. And although you don't have a monitor, the pulse oximeter, which is the much better monitor, you put on his finger, and his pulse rate's down to 38. 38. And he's feeling short of breath and having no pain. Now that's something different. So we got his heart rate down all of a sudden. He's feeling that shortness of breath again. The pulse oximetry still may be reading very high levels, so it's still 96, 98%. Sir, we may have found what is causing your shortness of breath. Suddenly your heart rate is very slow, probably lower than it should be. So we are glad that we gave you the aspirin because this is probably a cardiac problem. And when the medic crew gets here, we're going to relay this information, and you're going to be going to a cardiac center. So the Grady crew gets there. Gentleman is still at a very slow heart rate. We put the pads on, and at this point will be the fancy pads that we can do pacing with our monitor on the Grady rig. And as you're transferring him across, he's still doing okay, 98%. But before we get him into the back of the medic, the patient suddenly slumps over. And you've got your hand on his pulse, and you feel no pulse. And the paramedic says, we're in VFib. And so the current recommendation for treatment of VFib in the presence of providers who've been waiting for something bad to happen is we immediately defibrillate him. And we defibrillate him at the first shock level and hope that brings him back. Unfortunately, in his case, that first shock is not going to bring him back, and he's still in VFib. At which point, we're going to make a good decision about where we're going to be doing compressions. We lay him down flat. We start compressions on his chest at a rhythm of 100 to 120 beats a minute. We do that for about 2 minutes, and then the paramedic will say we're going to shock again. And then you lift your hands off for a second. The shock is administered, and your hands go back on the chest. We're still in VFib. Another 200 compressions. The paramedic says, stop. I'm going to administer a third shock. Your hands come off of the chest. The shock is administered, and the paramedic says, hang on a second. I have a pulse. I have a rhythm back. And that rhythm is at about 80 beats a minute. We haven't had to administer any drugs yet. We immediately feel for a pulse. We feel a carotid pulse. We feel for a pulse in the femoral area. We feel for a pulse at the elbow and at the wrist, and we feel pulses. We have had an OPA in place, and at this point, the patient is trying to spit it out. Okay, we'll take that off. We'll administer high flow oxygen, and at this point, the paramedic's going to say, okay, now we are going to load. We are going to go to a cardiac center. I'm going to give him some medicine to keep him from going back into VFib. I probably need a couple of people to go along for the transport to make sure that if we need to do compressions again, we'll be back doing compressions effectively. So using our new principles of approaches to American Heart Association, CPR and ACLS, that is how pit crew administration goes forward. Patient that presents originally with something that makes us worry about the cardiac system. And fortunately, we got aspirin aboard early enough. And that patient is likely to do very well, especially if they get them to a facility that has an interventional cath lab, and we can move them quickly into aggressive care for their heart. So advances in CPR, advances in ACLS. We are getting good resuscitation rates on patients who need it. Of course, our job always is to keep them from going into cardiac arrest. And so the medicines we do and the things that we intervene on for the patients, it's a really good way for us to be able to manage those kind of cases and keep us from having to do CPR. When we do have to do it, we are ready and prepared to administer using pit crew CPR that you all need to train on in the stations. All right, update on ACLS and a little mega code scenario for all of you. Let me talk about my Saturday night. I am at home listening to the radio. I hear a call go out, and the call originally is not that interesting. It's a report of a man injured. So we've talked about the law of inverse dispatching, which is all interesting calls are dispatched as nothings. So report of a man injured. They get to the scene and report, yes, there's a man injured. His arm is trapped in a machine. His arm is trapped in a machine. It's 4:30 in the afternoon on Saturday. This man works in a marina, and in a marina where they take the boats on huge forklifts and lift them up and park them out of the water. So these enormous forklifts, one of theirs broke down, and a repairman is attempting to repair it, and has his non-dominant left arm up in the machine as the machine fails and traps him up to the shoulder in the machine. Comes in, of course, as just a report of a person injured, and so a crew goes out with a medic unit and an engine, and they get there and find the gentleman is up in the air. They've got the other people from the marina there that are starting to assist him as they can. He's not in a great degree of pain, but his arm is thoroughly, significantly compressed, and he can't feel anything in the arm or the fingers. And he's 15 feet off the ground on one of the frame pieces. So the marina crew is working to stabilize to make sure that this doesn't fail. So they bring another lift over and point it into this one to hold up the component of the lift that had failed. The first responding engine crew gets there and says, "We need a ladder. Let's make it 2 ladders." Because we have access to this gentleman from the front and from the back, and to do any work on this, we're going to need to use both approaches. They point one of the ladders essentially right underneath his butt to get underneath him, and use the other ladder as a working surface. So the straight stick goes in underneath him, and then they put, for his comfort, they put a backboard on the end of the ladder and position it in such a way that all the weight is taken off of his trapped arm. He is in that position, and at that point is not in any medical distress. He is now in a comfortable position and is safe, and they don't fear that the lift is going to move or slip any further. They bring a tower ladder into the back of the lift. That will not be used for patient care. It will be used instead to study the problem and to begin to figure out how to resolve it. 7 hours and 15 minutes later, we're able to extricate the man from the machine. My longest extrication in a 38-year career. His arm is in the machine with us not being in a position to do anything. Last week, probably many of you read that in Oklahoma City, a man's arm went into a belt, and they had to call a surgeon to the scene to amputate the arm to get the man out. We were not in a position to do amputation because the man is strapped up into his shoulder. As a matter of fact, one piece of the machine had gone into his chest wall, and we couldn't even see that to figure it out. In 7 hours and 15 minutes, what do you have to do to sustain the life of a patient who is in front of you? So our job in the fire service is to be able to provide care for the gentleman, as we had an increasing number of experts come to help us figure out how we could piece this machine apart, this broken machine now, apart so that we can access the patient. So they had hydraulics people there. They had the forklift company people there. They had the marina people there. They had experts in the pistons that are used in those machines there. A significant number of people. There were 100 people there involved in this and in the decision making. And what's important is that we're communicating with the worker all the time. Of course, he knows his machine as well. And so talking with him, but then his comfort, the fluids that needed to go in him, actually, putting a little external device so that he could empty his bladder at an appropriate time, in 7 hours and 15 minutes with his arm trapped above him And this is a wonderful gentleman who knew his arm was toast, and that he was going to be lucky to get out alive. He would be lucky if further parts of the machine didn't collapse on him or decide to crawl further into his chest. And we had to be developing methods of approaching any of those things should they have occurred. Fortunately, at 7:15, we had a 75-ton crane on the scene, lifting the superior elements to make sure that they didn't fall, and then literally using come-alongs to gently lift the pieces that were above the patient off of him. And at a point where there's 3 come-alongs with 3 firefighters using them to very slowly lift the pieces of the machine off of him, supported by a 75-ton crane, we were able to get the arm freed, and then could slide him down onto the backboard, and then slide the backboard down onto the ladder, and then lower the ladder down to where everything prepared for this gentleman down into a waiting medic unit, out to a helicopter to take him to a center. I can tell you we had his family there with him and providing support from a distance. They did not interfere with the operations, and were a significant part of him being able to concentrate on what helped get him out. Not all situations can happen like that. In this one, it was very helpful to him. Number 2, a battalion chief early on hands his phone up into this gentleman and says, "Call your family and talk with them." One of my most amazing, events of my career. There was a gentleman trapped under a machine in a way that was going to end his life. And the first thing the battalion chief did was hand the man a phone, because he was trapped from right at his diaphragm down under a crane that had completely crushed the lower part of his body. And they knew as soon as they would lift the crane, the gentleman would go unconscious and we wouldn't be able to resuscitate him. So a battalion chief smart enough to say, the first thing we need to do is hand the man his phone and tell him to call the people that are important to him. And you talk with them and let them know as we begin to do our work here. So in this case, the gentleman had talked to his wife on one of our phones, and then over time, as we realized how long this was going to take, originally referring these people to the hospital, but then saying, no, he's here, and if you would want to come here, and then setting very strict stipulations about where they could go and how they could participate in communicating with him. But obviously, when he was being wheeled out to the ambulance, he had a chance to reunite with his family before he was flown to the trauma center. A very interesting case in my life. I'll probably write it up. I've had other amputations done. I've had other, they were done by the machines. We've had other times when I've helped extricate people out of machines, and other times when we considered and had to do amputations on people to get them out of the machines. So a couple times in your career, you're going to face these events. Really important to be organized, safe, and the important point, there's 100 people who worked that scene with all kind of very, very heavy equipment, hydraulic fluid at high pressure, kitty litter everywhere, and no one amongst the rescue crews and amongst the other technical staff was injured. So a mark of success of an operation that took 7 hours and 15 minutes to play out is that we all went home safely afterwards. With that, I'm going to end this month's training, and I'm very grateful to be back working with all of you. Monthly trainings, if you'll get me any topics that are of interest to you, I'm always happy to work on what you want to be trained on. Really important this year that we get new protocols in place, get our drug boxes in place, get everybody comfortable using the equipment and the stuff that we have, and that we're ready for a season that'll be a little different because people, thank goodness, we're going to not use the words COVID every time we speak, and we're going to be back to taking care of our community. We're going to be back to teaching in our community, and all of the things that you love doing. We'll be able to go to Braves games again, and by the fall, hopefully, college football and everything else will open up for us. So what a tremendously difficult year for all of you. We mourn all of the losses that occurred this year across all of the things that we had to face. And we have to look for a much better next year ahead. You all take care of yourselves. Let me know how to help you. I'll be in touch. Thanks a lot.